This is Dr. Lyle Jones, Editor-in-Chief of Continuum, the premier topic-based neurology clinical review and CME journal from the American Academy of Neurology. Thank you for joining us on Continuum Audio, a companion podcast to the journal. Continuum Audio features conversations with the guest editors and authors of Continuum, who are the leading experts in their fields. Subscribers to the Continuum Journal can read the full article or listen to verbatim recordings of the article by visiting the link in the show notes. Subscribers also have access to exclusive audio content not featured on the podcast. As an ad-free journal entirely supported by subscriptions, if you're not already a subscriber, we encourage you to become one. For more information on subscribing, please visit the link in the show notes. AAN members, stay tuned after the episode to hear how you can get CME for listening.
This is Dr. Allison Weathers. Today I'm interviewing Dr. Leslie-Mazwi about his article on neurocritical care for patients with stroke due to large vessel occlusion, which is part of the June 2024 Continuum issue on neurocritical care. Welcome to the podcast, and please introduce yourself to our audience.
Hello, Allison, and thank you very much for the opportunity to contribute to this continuum. My name is Leslie-Mazwi, as the audience just heard, and I am a professor and the chair of the neurology department at the University of Washington in beautiful Seattle.
Great. Well, I really appreciate you being with us to speak about this fantastic article. As I was mentioning to you before we actually started recording, I am not a vascular neurologist, and so this was a really fascinating topic for me to learn more about. And actually, that's my first question for those of us who aren't as familiar in managing stroke due to large vessel occlusion. Can you start by explaining who are the various teams involved in the care of these patients, and what is the role of the neuro ICU or the critical care neurologist in the management of these patients?
That's a great place to start. I think many of the folks listening to this will be aware that there have been dramatic changes in the world of stroke, and particularly driven by how we treat large vessel occlusion patients in this last decade. And the neuro ICU is not separated from those changes. In fact, I would argue it is central in those changes. So the neuro ICU team is interfacing with all the other teams that are caring for these individuals in this incredibly time-sensitive disease. And that extends from EMS crews through to ED physicians and other clinicians and providers, through to the endovascular and anesthesia teams, and then obviously rehabilitation teams and medical teams that are consulting on these patients in the ICU environment. It really is a team sport, and I must say, for me, that was one of the things about critical care and stroke that I was always so struck by, is how many people have to work and pull together for patients to have the best outcomes.
I think that highlights such a really important part of the care of these patients, as well as the role of the neurocritical care to really almost be the coach of that team, to organize all of those moving parts and pieces to ensure that the care stays on track. And these can be such complex cases with so many, things going on, and there's so many challenges. What would you think, or in your mind, what is oftentimes the biggest challenge in managing patients with strokes due to large vessel occlusions?
There are many challenges that I think care of these large vessel occlusion patients brings for the neurocritical care unit or otherwise. I would say that actually two that are most prominent are the need for timely evaluation and triage and treatment. And, you mentioned a second ago the number of teams involved. The coordination of all of that is so important. And that's something a neurocritical care unit can really help with. We just aren't getting to our patients as quickly as we should. And that's a systems of care issue. The other important challenge that we face is that despite having a highly effective treatment, we still have a sizable proportion of patients that have challenging outcomes. Half of our patients still have challenging outcomes. And understanding more about that group of patients and how we can assist them is going to be one of the challenges for the future.
Such an important area. And I keep kind of going back to, it almost sounds trite, but as I keep saying, as a non-vascular neurologist, but as somebody a little bit on the outside kind of looking in, to me, that seems like such a challenging area. You do these amazing rescues. It seems like you do, in many cases, get to these patients so quickly and induce these miraculous interventions, but seems to be miraculous. And then still, despite everything, there are sometimes these not good outcomes. And I think, to your point, understanding that and being able to prevent that would really be the magic bullet, if you will. Moving on. So, from kind of the biggest challenge to the biggest misconception or most common misconception, what is the most common misconception that you've encountered in treating patients with this disease condition? And kind of along those same lines, what in the article do you think would most surprise our listeners?
I think the historical nihilism that has gone along with large vessel occlusion stroke is perhaps the thing I'd answer to your question there. We have these expanding and highly effective therapies. In fact, thrombectomy is one of the most effective therapies in the history of medicine, much less in cerebrovascular neurology. And to be able to implement that and overcome literally generations of nihilism about the fact that these patients have large strokes or are at risk of large strokes, I think has been an interesting element in my personal career with this entity. In the article, I think there are several things that will surprise people. One that I hope does strike them is the emphasis on rehabilitation, family communication, and the future state of the field. We're talking about where things are now in the article, but there's some very exciting things to come as well. And some of those, I think, will impact that 50% or so of patients that still have challenging outcomes despite effective treatment.
I really appreciated how forward thinking the article was and that emphasis on rehabilitation and involvement of the family. I hate to move us from such a kind of positive to a not so positive, but I do think it's important to think about for our listeners to learn what, in your experience, was the easiest mistake to make, and therefore what should be avoided when treating patients with large vessel occlusions.
I think it's easy to underestimate how tenuous the condition of a large vessel occlusion patient is in that first 24 hours. As you say, for patients that undergo thrombectomy, it can be almost miraculous. It can be like a resurrection, is how I often think about it. I don't think there's any endovascular procedure that is as gratifying as thrombectomy for stroke. So these patients come back and they're starting to improve, and it's easy to forget that there are still a range of dangers they face. Hemorrhage from the access site is a clear and present danger. The risk of hemorrhagic transformation is a clear and present danger. The risk of stroke progression despite reperfusion is a clear and present danger. And that's for patients that have thrombectomy. Then you have the large vessel occlusion stroke patient that isn't a candidate for thrombectomy for a variety of potential reasons. And they too are immensely fragile. And the ICU is aiming to support their perfusion, to support their homeostasis as much as possible to limit the risk of ongoing damage or worsened damage from the occlusion that they are suffering from. Let me talk a little bit more about the access site considerations, because that's an important one, and you'll see in the article there's a table that outlines this. We are monitoring patients for neurological changes, and it's not hard to forget that they have an access point. And historically, that access point has been femoral, so the puncture site is in the groin, almost always the right groin. Increasingly, I think we'll see radial access for stroke patients, but these systems are large systems, and the radial artery can't always accommodate what you'd need to put up into the intracranial circulation to extract clot. And so femoral access points are under the blanket. The patient is lying in bed, and it's easy to forget that that might be the culprit in the context of, say, unexplained tachycardia and then hypotension, pain, or urinary symptoms. And so these patients are at risk of developing local hematomas. They're at risk of developing retroperitoneal hematomas. And they're obviously at risk of bleeding at the site onto the bed. One of the common mistakes that people make is when a groin access complication is detected, they rush to call for help. And really, the first step should be applying pressure to that groin site. It's a compressible arterial puncture site. You have to apply pressure to the bleeding point and then call for help. And that pressure needs to be maintained until help has arrived and the groin can be evaluated by the endovascular team or other members of the neurocritical care team. I would also say for radial access, the complication rate is very different and substantially lower. And that's one of the reasons why the entire field has been moving to radial access as opposed to femoral access for all endovascular procedures in the neurospace, stroke notwithstanding.
I think really very key advice for our listeners who are involved in these kind of procedures and these kind of decisions. Moving on from kind of the easiest mistake to kind of a harder question, I think, what is in your opinion, the current biggest debate or controversy in the topic of patients with stroke secondary to large vessel occlusions?
I think the debate is hottest in the realm of who is a candidate for thrombectomy. We had the trials in 2015 that really established the beachhead of thrombectomy as the gold standard treatment for patients within 6 hours of their symptom onset. And what we've seen since that time is just progressive expansion in terms of candidacy. The first expansion point was to patients that have large vessel occlusion strokes within 24 hours, so pushing the time window out further. Recently, we had a very important expansion into patients that had pre-existing infarct cores that were large. So they already had a big stroke coming in. Were they candidates for thrombectomy or not? And the answer was a resounding yes. There's ongoing effort right now looking at patients that have more distal occlusions. Instead of an internal carotid artery or middle cerebral artery or basilar artery occlusion, what if your occlusion's further down in the vascular tree? Does chasing that clot help patients or not? And then the population of patients who has a proximal occlusion, but well enough maintained collateral circulation that their clinical deficit is small. Is it better to support those collaterals and let the patient sort of equilibrate? Is it better to take those patients for treatment? That's an unknown at the moment. And so I think the idea of expansion of thrombectomy is probably the most hotly debated area in the space at the moment. If you think about our role in the neuro ICU, we support patients in all of those different groups. And so we play a background role in that thrombectomy conversation as to whether a patient should go or not, and if they go, what they need to protect them post-procedure, and if they don't, what they need to prevent them requiring a procedure. And I'll give you the example of a patient that has a proximal occlusion, but a well-maintained neurological exam. To the point I made earlier about the fragility of these patients, that's a patient who is walking on a tightrope, and they need to have their perfusion supported. They need to have continuous blood pressure monitoring, which means an A-line. They need to have very clear blood pressure parameters. That includes a blood pressure floor, not just a ceiling. And so you say, I want this patient to always be above systolic blood pressure of 120 or MAP of 80, depending on what their baseline variables or baseline blood pressure readings are. They need to have frequent neurological exams. They need to be euvolemic. And if they have an exam change, help needs to be mobilized fast to potentially take them down for thrombectomy. So you can see in just that example how central the neuro ICU is in supporting those individuals in their hour of greatest need.
Absolutely. And I think that's, obviously a recurring theme, the main theme of the article, and certainly throughout this whole conversation, that regardless of the intervention of the patients, that role is just so paramount. Again, multiple teams are involved, but really a very central role until the patients are very stabilized and able to leave the ICU setting. I want to turn to a more personal question and learn a little bit about how you became interested in this topic and this patient population in particular. As a vascular neurologist, what especially about patients with large vessel occlusions and the role of the ICU in their care interested you?
Oh, that's an interesting and unexpected question. I would say I'm a neurocritical care neurologist by training, and I did a neuroendovascular fellowship after my critical care fellowship. And I've been an attending for a few years when we had the new thrombectomy devices, and then subsequently the trials that demonstrated their benefit in 2015. And what struck me then was that we had such an opportunity before us. Now, I always think about the patient or the patient's family calling 911 and the amount of faith that they put in our system to pick them up, to bring them to the right place, to give them the right treatment. And we had this immense body of evidence about what the right treatment was. But I felt that we were moving a little more sluggishly than was ideal in implementing that evidence for patients' benefit. And so that's what got me into the specifically large vessel occlusion space. And I would say in all of neurology, I think it's been the most dynamic and interesting space in this last, maybe the last decade, maybe the last 5 years or so. It's just been incredibly active. And so I feel very fortunate that I've been able to be part of all of that change.
I think that's an incredible answer. And I think it's wonderful how much that you and the field overall has been able to do for these patients who, if you think back to 20 years ago, I like how you framed it at the beginning, it was a really nihilistic approach. And, a phrase that you often hear, generally not as much anymore, which is nice, but it used to be very much the self-fulfilling prophecy, right, in the ICU that, oh, well, they're not going to do well, so we can't intervene or we shouldn't intervene. And I think we've really, especially with the evidence that's now come out in the last decade or so, gotten away from that more and more. And the outcomes have been incredible for so many of these patients.
I would agree. I think it's easy to forget how devastating a disease large vessel occlusion stroke is, right? It's the main reason you die of a stroke. 90% of the mortality in stroke is from large vessel occlusions. It's the main reason you have severe disability after a stroke. About 75% of the severe disability after strokes is in patients that had large vessel occlusions. And so if you think about the societal burden of that on our population, on our patients, and our opportunity to diminish that with effective treatment, it's really a breathtaking time.
And I feel like you've led me right into my last question. So I say people who've listened to my other interviews know that I always love to end on a positive and hopeful note. So my question to you is, what do you think the next big breakthrough will be in the management of patients with stroke due to large vessel occlusions? And what is exciting to you about the field and what's to come?
Wow, that's a big question. I would say if I start at the neuro ICU level, I think we're going to see increasing refinement and improvements in our systems of care. Like all systems, if you're coming from an engineering background, all systems can always be improved, right? And so the system of care for stroke is no exception. And I see that as work for all of us, for all those teams that we started this conversation referencing. I think on a more imaginative level, we are going to see a rebirth in our neuroprotectant space. We have effective reperfusion now. I think we're going to gain a better understanding of the ischemic process of damage and the cellular and molecular changes that are happening. And I think we'll see neuroprotection see a resurgence. Again, I think that the neuro ICU will be critical in supporting and delivering. And then in this era, it's hard to have any conversation about the future without a reference to the promise of artificial intelligence. And I'm a very ardent believer that AI offers us in medicine and our patients, by extension, an incredible chance to supercharge and improve the way we do things. There are multiple ways you could imagine that happening. There are multiple ways that have been described in the literature up to this point. I'll give you an easy example from the neuro ICU, where there's an immense amount of data that's being captured in each patient. And to be able to manipulate that data and use it in real time to predict physiological state changes, I think is a very realistic near-term goal. So I think the future is immensely exciting.
Well, thank you so much, Dr. Bay Leslie-Mazwi, for joining me on Continuum Audio.
Thank you.
Again, today we've been interviewing Dr. Leslie-Mazwi, whose article on neurocritical care for patients with stroke due to large vessel occlusion appears in the most recent issue of Continuum on Neurocritical Care. Be sure to check out Continuum audio episodes from this and other issues. And thank you to our listeners for joining today.
Dr. Tisha May Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, you'll love the journal, which is full of in-depth and clinically relevant information important for neurology practice. And right now, during our spring special, all subscriptions are 15% off. Go to contendpub.com/spring2024 or use the link in the episode notes to learn more and take advantage of this great discount. This offer ends June 30th, 2024. AAN members, go to the link in the episode notes and complete the evaluation to get CME. Thank you for listening to Continuum Audio.